So again, this presentation represents our statement. It's 2022 statement published in 2023. You can see a number of people in this room and other people, both physiotherapists and surgeon colleagues, were represented in this very large group. It was an attempt to answer 8 questions. 3 of those I'm going to emphasize because, as you will see, the follow-up presenters in this session will in detail address these other questions that we have. So I'll only briefly mention those at the end. First question that we attempt to answer is, well, what is greater trochanteric pain syndrome? How do we define it? How do we define it in general and in relation to physiotherapy practice? And our consensus statement was that the term GTPS encompasses multiple diagnoses, including external snapping hip or coccyx ascendens, proximal iliotibial band syndrome, trochanteric bursitis is still in there, and medius and minimus tendinopathy or tearing. We do know, of course, lateral hip pain is not new. It's been around for a long time. Traditionally, we probably have blamed the Bursa a little bit too much. This broadens our potential source of symptoms to help not only help us diagnostically, but also help to drive our interventions, hopefully make them more specific, more efficient, and more effective. The second question that we attempted to answer is to get a consensus on what about the differential diagnosis. And it's important to note we're looking at this from 2 perspectives. Is it a differential diagnosis where we don't think it's greater trochanteric pain syndrome that we are working with and we have to change the course? Or probably, and maybe more commonly, is it a coexisting issue that we have to then determine if that is the case, how do we prioritize our treatment, or at least take a number of different diagnoses into account? And our consensus was, again, when evaluating greater trochanteric pain syndrome, differential diagnosis should include intra-articular hip disorders, lumbosacral spine disorders, and muscle tendon disorders of the hip. We know the typical presentation, primary pain at the lateral hip, symptoms that may radiate down to the buttock and lateral thigh. Often these symptoms are aggravated by direct pressure, such as an ADL is lying on your side, or loading, such as single leg loaded activities. We do know that is more commonly observed in females, particularly those over 40, peri and postmenopausal women. Those are also groups of individuals that you will see a number of these other issues that we just mentioned. Do they have groin pain? Do we have to consider osteoarthritis? We look for that telltale morning stiffness, a capsular pattern. FAIS can also not be discounted out here, along with other intra-articular issues. So we may have to look at our screening examination for intra-articular hip disorders. Lumbosacral concerns. Early in the 90s, colleagues noted that there's a coexistence of in the neighborhood of 18 to 45% of low back pain with individuals who also had lateral hip pain. So again, we may pull out salient components of our lower quarter screen looking at the spine along with the lateral hip. Proximal hamstring, probably not so much a differential, but definitely could be coexisting, and we mentioned that earlier today during the posterior hip talk. Deep gluteal pain syndrome, this can be a challenge when we have to consider 2 syndromes. Can you open a large box of differential diagnoses that you may be working with? And I think often, at least in my experience, inevitably makes it a very difficult and probably a lengthier rehabilitation episode than may already be. Okay. Again, noting, and I guess luckily you could say that most of the tests, special tests of the hips are actually better suited towards screening, so may be very suitable here, considering the lower quarter or the lumbosacral spine, and perhaps that deep gluteal area is a coexisting diagnosis or set of diagnoses. Third question, what is the appropriate physiotherapy management of GTPS? And this involves both the physical evaluation and impairment-based treatment. And the statement went, physiotherapy management of GTPS should be impairment-based, targeting the deficits identified during the physical examination. And that's not to downplay the special tests that have been described, but we do know that these tests really, or cluster tests, really don't differentiate between specific pathology, those pathologies that we already mentioned, and or the extent of injury. However, the clinical evaluation should include a palpatory examination. And around the trochanteric area, you may be able to differentiate between gluteus medius and minimus involvement depending on where the trochanter they are tender. Symptom propagation tests, you'll see the Faber test described in the literature. Of course, that test has been described for many other disorders as well. Tension-related tests, combining some passive active or both tension placed across the tendinous structures, in an attempt to create compression at the trochanter and reproduce pain, and we'll mention a few of those in a brief moment. And then single limb stance also. I do note in single limb stance, I do use that on some of my more athletic individuals. I like to use a more dynamic single leg test, so step down or single leg squat as well, even though that may not be described as much in the literature. Okay. Probably one of the more commonly described tests, the gluteal derotation test, where the individual is passively flexed to 90 degrees, the hip is placed into end range external rotation, the patient derotates back to neutral while against resistance, and you're looking for reproduction of lateral hip pain or their primary symptom. Since we released the consensus statement, there have been a number of follow-up tests. Grimaldi and colleagues looked at 65 patients undergoing MRI for lateral hip pain. You can see the tests that they looked at here, many of which we already mentioned, and a number of other tests that involve, again, placing tension across the gluteal tendon structure in an attempt to create compression at the trochanter for reproduction of pain. They came to the conclusion that lateral hip pain with 30-second single-limb stance test, likely to have gluteal tendinopathy, lateral hip pain without palpable trochanteric pain, unlikely to have a gluteal tendinopathy. And in the case when someone has a positive MRI for a gluteal tendon tear, to qualify or to make the connection between that finding and the gluteal tendon, the clinical tests that were most useful were palpation plus resisted clinical tests, many of which we have listed here, all of which we have listed here. And it really means just one of those tests, not all of them. A very recent, I think it was August, systematic review looked at the accuracy of clinical tests that are used to diagnose GTPS. They started with 858 studies, but really only 6 underwent full literature review, and they came to the conclusion that a negative gluteal tendon palpation test and negative resisted hip abduction test decreased the post-test probability of GTPS from 59% to 14%. In comparison, a positive gluteal tendon palpation test and positive resisted hip abduction test increase the post-test probability of GTPS being present from 59 to 96%. Most of these studies, including this SR and MA, tend to be in general agreement in regard to the findings and what they mean. All that being said, most of these tests do not really guide our rehabilitation, right? They don't tell you what to do. They may help qualify the diagnosis, but our impairment-based or our treatment progression or our treatment in general is based upon our impairment findings. So when we look at this, we are obviously looking at strength as one potential impairment, but we should also differentiate that muscular endurance is also very important to look at. And what do we mean by that? So a 1 repetition maximal test may give you information side to side, maybe they're weak, but what happens over time? Because we do know to keep the pelvis level with various activities that we may be involved in, that is very much an endurance-based activity. So again, differentiating the two. Appropriate load and dose progression from an isometric concentric to eccentric progression, but we also have to account for tissue irritability, and I'll speak a little bit more to that later, particularly in this population, which often is dealing with somewhat of a chronic pain condition. Motor control deficits, specifically those in the frontal plane, and remember, motor control deficits may be strength, as I mentioned, fatigue, as I mentioned, but also may simply be an issue of motor control, and the intervention strategies may vary when we're treating those individuals. And we have to differentiate that in our physical examination. And this is only 2 of many studies that exist that you can use as a reference in regard to EMG studies in exercises and that selectively recruit the gluteus medius minimus, or in the study on the left, which has been around for some time, the recruitment of those muscles against the TFL, which is a muscle you typically don't want to recruit in many of our intervention strategies. But it's also important to note that while this information is useful, as I mentioned, you have to take into account the tissue irritability and what happens when you perform some of these exercises. Because you could choose an exercise that has a high recruitment profile for these muscles, but if it creates a very high compression load across the trochanter, it's painful, then it's probably not that effective, right? You may be making the condition worse or the clinical presentation worse. So as we note here, again, the side bridge, very high recruitment profile. Doing an isometric position is, that's my wife who has a labral tear. It's probably better to do that as opposed to going up and down numerous times, because as soon as, I think there's a study from 2004, as soon as you draw up 10 degrees below the neutral plane, you increase the trochanteric compression load 9 times, right? It's not a linear relationship. It goes up greatly. Again, thinking of an RDL, a great recruitment profile. However, if they're doing this incorrectly, dropping into that adduction or valgus moment, now you're significantly increasing those compressive loads that are experienced at the trochanter. So again, take into context not only the recruitment profile, but what is happening mechanically at the trochanter, and are they ready to do that exercise? And irritability, again, plays a role here. Anyone who's seen me present knows I get a lot of mileage out of this because we put a lot of money into this study, and this is about all I got out of this is this slide. So again, motor control. You can see here when the individual on the left, the same individual, young lady we work with, very good control, but when she drops down to that valgus moment and step down, you can imagine the trochanteric compression loads that are experienced there. Again, it may be strength, may just be pain, but also it may just be the fact that she's not effectively doing this, and this may require more external cueing, initially applied in a predictable fashion, then removing that cueing so she internalizes the response to correctly perform the exercise. And that carries over to other single leg loaded exercises as well. This is a busy slide, and I just want to give credit to Rob and our colleague Ashley DeSantis from Pittsburgh, who's not here, but it is a classification-based treatment for GTPS with integration of the movement system. But I want to particularly point out here is there's an irritability consideration here, high, low irritability, how you may adjust your treatment based on the level of irritability. I think it's very important. It's important in any population, but as I mentioned, the chronicity of what people experience with GTPS, if you make them irritable very early in the process, you may not get the buy-in. We know that the disability with GTPS in some people is equal to that of end-stage osteoarthritis. There's literature to support that. So they're very sensitized, many of these people coming in to see you, and if you don't have some success right away in the buy-in, that's going to be problematic. Again, patient education. There's a pretty decent amount of literature out there on this. Basically, that it comes down to positioning, education to decrease the compressive loads that are experienced at the trochanteric region. And that includes sleeping position as noted here as well. Okay. And I did note again, we have 5 other questions that we sought to answer and come up with a consensus with. But however, there are the 2 buckets. One is pharmacological agents and rehab associated with that. The other are surgical indications and the rehabilitation associated with post-surgical intervention, which will be covered throughout the rest of this session. Just a quick note, you'll hear about it. I think Ashley mentioned too, focused shockwave treatment is becoming a more popular choice of intervention, and there's literature that is mounting to support use of this modality for this population. Other than that, our rehabilitation summary is that, again, it is a syndrome with numerous potential causes. Tendinopathy is becoming much more of an accepted, I think it is the accepted cause in many cases for lateral hip pain. Maybe we're downplaying the Bursa, probably should have at some point all along. Historically, passive stretching and passive treatments and stretching were emphasized, but now we're looking more at more active approach, motor control, strengthening, but still taking into account the compressive forces that are experienced at the trochanter. Patient education is paramount in this population, and then again, perhaps in the future we'll have more to say about focused shockwave treatment as well. Thank you.